Buongiorno, everybody, and welcome back to the Journal Club. Delighted that you're all joining us again today. So today we'll be discussing the topic of intravascular lithotripsy, or if you like, shockwave, for treating calcific coronary disease. Our presenter today is Pierluigi Demola, who will be presenting this paper. And it's a great pleasure and a very warm welcome to Professor Carlo Di Mario, a true expert and visionary, not only with calcification and treating this, but also interventional cardiology. So, Prof, a big thank you from all of us young interventional fellows for joining us for this Journal Club initiative. So we'll start off with Pierre's presentation, and afterwards we'll have a Q&A and a discussion session for about 10-15 minutes, and we'll aim to finish by 8 o'clock. So Pierre, if I can invite you to share your screen.
Yes. I don't know if you see it.
Perfect. Let's go.
Thank you very much, Arif. Nice to see such crowd in the morning, such early in the morning. And I want to thank you, Professor Di Mario, for my fellowship in the last 2 years. As a very thanks to him. And today we're going to talking about in this Young Journal Club of a patient-level pool analysis of disrupted studies. I have no potential conflict of interest. As all we know, coronary artery calcification is age and sex dependent and also more common in white people, in Caucasian people. Patients with severely calcified lesions are elderly with numerous comorbidities and grow in demand for revascularization with an increased periprocedural complication and more long-term adverse events, and were mostly excluded from randomized PCI trials with poor evidence for best PCI practice. The more severe the calcium, as all we know, the worse the outcomes. So there's a major percentage of death, cardiac death, and MACE in general. As we know from several also meta-analyses of these PCI trials, there are coronary calcification is an independent predictor of prognosis, and an increased arc of calcium leads to decrease in stent expansion with poor outcomes. So lesion preparation is pivotal in coronary calcification, and which are our weapons. Firstly, high pressure balloons, scoring cutting balloon with a focal concentration of dilatation forces with controlled incision of the lesion, and high-speed rotational atherectomy, such as rotablation or orbital atherectomy. And in the last years, this newborn intravascular lithotripsy that was motivated by the lithotripsy of the kidney stones for vascular calcification using less energy, obviously, with a pulsatile acoustic pressure waves that spread through a generator with an electrical energy is spread to the shaft and the emitters, and then the emitters deliver this unfocused energy into the contrast filled balloon. And this forms in the emitters and in balloon these steam bubbles that expands and collapses, creating the sonic pressure wave. This kind of coarctation a wave that can disrupt both superficial and more deeper calcium. This is the generator that is emitting the energy, and in the balloon with 80 sonic pressure waves delivered 1 per second, they are able to disrupt to make macro cracks and micro cracks, both in the intimal and in superficial and medial calcium. Expanding and collapsing these vapor bubbles creates a short burst. So as we see in the first attempt, that sonic pressure wave goes hard on hard and soft on soft, sparing for the first in the first attempts the gelatin of an eggshell, and making cracks in the eggshell, minimizing the trauma, optimizing outcomes, and simplifying a procedure that is very hard nowadays. So the advantages of coronary intravascular lithotripsy are several. There are mainly, it did not require specialized wire. Shockwaves pass through the plaque vessel wall, enabling modification of calcium and disrupt the calcium in the vessel, reducing the risk of distal embolization without embolized debris in the distal coronary. Lithotripsy allows calcium modification to be performed at low balloon pressure, 4 to 6 atmosphere, and thereby avoiding the risk associated with balloon inflation. And we are also able to protect side branches with a second wire. And the main thing of this system is the intravascular lithotripsy is easy to learn compared to other forms of calcium modification. Many EVLs catheters are developed, but the one that is used in coronary arteries is the C2 with 2 emitters diametrically opposing of 180 degrees with a pressure form that is in red in this line. As you see, there's much bursting in energy, bursting in atmosphere at the localization, precise localization of the emitter. So at the end, it's more like a karate chop than a weightlifting. It's like a bursting of 50 atmospheres just in one single side. So as we see the cracks in the OCT, we are able to think that only macro cracks permit to expand. But in cadaveric specimen, also micro cracks are very important to the final stent expansion. The aim of this pooled analysis that was published in JACC Cardiovascular Intervention and presented in May by Robert O'Reilly at American College of Cardiology was to assess the cumulative safety and effectiveness of coronary intravascular lithotripsy. This individual patient level pool analysis was made by 628 patients around 72 global sites in 12 countries with uniform study criteria, endpoints, adjudication, and follow-up. The primary safety endpoint was 30-day MACE with cardiac death, MI, and target vessel revascularization. Primary effectiveness endpoint was procedural success, successful stent delivery with residual stenosis less than 30% without in-hospital MACE. At multivariate analysis where predictors of MACE and procedural success were analyzed, and safety and effectiveness subgroup analysis. The disrupt cut study characteristics involved in the endpoints, periprocedural MI definition, maybe the more controversial thing that was taken as reference, the raising three times of CKMB. The target lesions were severely calcified, defined as radiopacity, in both sides of the vessel, more than 50 millimeters length by angiography, or a calcium angle of 2070 degree by OCT or IVUS. The target was the lesion was treated with balloon from 2000.5 to 4 millimeters, and the definition of length was different in CAD1 and CAD2, differently from CAD3 and 4, because the lesion length was taken about less than 32 millimeters in CAD1 and 2 and upgraded to 40 millimeters in CAD3 and 4. So not such a easy patient, as we see also by the baseline clinical characteristics, were predominantly male with hypertension, hyperlipidemia, less diabetes mellitus, and current former smoker, roughly half. As the core lab adjudicated that the most treated vessel was LAD, with reference diameter vessel of 3.0 plus 0.5 millimeters, and the calcified length was about 41 millimeters, and the core lab adjudicated that 97% were truly very severe calcification. The post-procedural characteristic, as we see, the procedure was conducted in a reasonable time of roughly an hour, with predilatation in a half of patients, and EVL catheters use was 1.3, and the pulses was 80 for all the balloons, but it was utilized about 74.7 emission per lesion, and the number of stent delivery was 1.3. The stent delivery as a percentage of success, nearly 100%. The most access that used in this kind of patient was radial, then femoral, and the access data was collected only in CAD 3 and 4. There's a minimum lumen diameter gain with a best gain after IVL and after post-stent. This because the delivery of stent permit to expand further, also utilizing the microcracks that are not seen in a common OCT, common coronary imaging, with a post-IVL diameter stenosis of 35.4% and post-stent of 12%. Again, post analysis with core lab analysis adjudicated as severe dissection, just 1.8%, all resolved with final post-stent application, with a low percentage and final result of perforation, all resolved with covered stent. And the slow flow was 0% in the final post-stent, with no reflow both after post-IVL technology and post-stent. There's the primary safety endpoint demonstrated as a consistent safety across all the disrupt CAD studies. So it's easy to use and also safe because it is a balloon-based technology that's very common in PCI. And in hospital and 30-day MACE, there were like 6.5% of MACE in hospital and 0.2% in cardiac death. And all MI were with the protocol of CKMB up then 3 times at the discharge was 6.4%, with the target vessel revascularization very, very low. The primary safety endpoint as a procedural success with consistent effectiveness across all the 4 disrupt CAD studies, as we see in all procedural success, both from CAD 1 to CAD 4. The secondary endpoints at 30 days as a 7.2% of target lesion failure and a very low percentage of cardiac death and very low percentage of stent thrombosis. As we see, the independent predictors of this MACE 30 days in the multivariate analysis was mainly the presence of a bifurcation that is defined by the rising of a side branch in the target vessel treated with a diameter more than 2.5 millimeters and the presence of a prior MI. The intravascular lithotripsy shows that in this pool analysis, there's a very low percentage of MACE at 30 days with a high procedural success of 92.4%, and was the cohort was the largest nowadays possible to see in a study. So the conclusions of this paper is that the disrupt CAD pool analysis represent the largest assessment to date of intravascular lithotripsy treatment de novo of calcified coronary arteries to facilitate stent implantation. This pool analysis outcomes demonstrates also the safety and the effectiveness in this complex calcified pattern, and consistent outcomes were achieved across trials despite new user experience across the centers and the countries. So it's a safe and easy procedure. Subgroup analysis demonstrate consistent coronary intravascular lithotripsy treatment benefit across multiple high-risk patient and lesion cohorts, and also consistent with prior PCI studies, bifurcation lesion, prior MI, and longer lesion length were independent predictors of increased MACE at 30 days and poorer procedural success. And now I want to thank you, Professor Di Mario, and I try to make some perspective, like the importance of routine coronary imaging in severe coronary artery calcification as a novel indication for this wonderful technology, the IVL, and the comparison of intravascular lithotripsy to atherectomy techniques and combination therapy. Thank you for your attention.
Okay, great. Thank you, Pierluigi, for a wonderful presentation and overview of this topic. Professor Di Mario, it's a real pleasure to welcome you, and thank you very much for joining all of us, especially so early in the morning. So if you'd like to share with us some of your thoughts and perspectives, both with lithotripsy as with your experience for us young fellows, but also from this paper that was published.
For having me here, and a very nice initiative. And I see 51 people connected. Well, first, this is a large study. 28 patients is the largest with technology. Is very controlled. You have seen this is all adjudicated. This is a registry only by name, but all the rest was as well monitored as the best randomized trial. But it's not randomized. And the reason why it's not randomized is not that the company was short of money. The FDA believed that there wasn't a technology that was considered a gold standard for treatment of calcified lesions. Eclipse orbital atherectomy against high pressure balloon dilatation had a very high crossover rate, had a few issues for what we hear. The study is not yet reported, and they decided to go for a large controlled registry to start. So these, of course, tell us that the technology is safe and effective. That's all what we know, but we don't know when we should apply, whether we should limit ourselves to the 1, 2, 3% of cases where nothing is able to open up those calcified, extremely resistant lesions, or we should try to improve results in those 15, 20, 25% in our elderly patients that we treat nowadays that have severe calcification, and how to select them purely angiographically using imaging almost in all cases. I think there are a lot of open questions for this, and well, I see some from the group. I don't think we have all the elements to answer, but I will do my best to tell you what I believe.
Okay, thank you. So if we take the first question from the group then, which is about, the question is, which are the vessel or plaque characteristics that guide you in using shockwave alone, or might make you think of using combination calcium modification devices like RotaShock?
Yeah, I mean, first of all, I think I never think of using a combination as a start, with extremely rare reception of very diffuse calcific disease where it's obvious that nothing crosses. At that point, I think I will go for a 1.5 balloon and follow with an IVL. I saw yesterday a procedure, and Pierluigi knows the patient I'm alluding to, done by an expert operator, 1.5 millimeter balloon. He felt that the lesion was modified enough to receive a stent, and at the end of the day had to use after the stent an IVL balloon. So I think a rotational atherectomy has now a very limited role, still is important, but just for uncrossable lesions. So I think the treatment of calcium from now on is more likely to be assigned to devices that are safer, that do not create any particles, that are easier to use. You have seen 6 French 60 minutes for complex procedures and extremely good results. So that's essentially what I think of this RotaShock that is interesting to collect. I know Professor Sardella is putting together a large series of these cases, but well, yeah, from what I hear, the series in Italy at least is still quite limited.
Okay, thank you.
We've used 5 so far in our hospital, and we have done more than 150 shockwave overall.
Okay, thank you. So I'd like to invite, if there's any other questions, if people would please come onto the chat and share their screen, and we can turn on the video and we can take some questions now from the audience.
Good morning. Good morning, Pierre. Good morning, Professor. This is Julia. I'm asking about laser therapy. Do you think that there is room for laser therapy, or the only alternatives are EVL or atherectomy for uncrossable lesion?
Thank you for the question, Julia. Of course, it's nice to have everything. And if you still have this big machine somehow in the cellar of your hospital, don't throw it away and keep some 0.9 catheter available, because I mean, in rare cases where you can't get microcatheters or balloon across and you crossed a CTO with a wire, well, laser can offer an easy alternative than going around it with a second wire and so forth. However, I confess, right now I don't have this technology available anymore, and I don't miss it much, because I think that the main indication that we were using it for in the past, that was expansion of stents, well, it was somewhat unpredictable the way it was responding. You had to do it in contrast to create this exploding bubbles inside the vessel, but the response was much less predictable than with a device that is built to do that, and that works almost always in restenosis of stents due to incomplete expansion, or in stents that you just placed but you found out that didn't expand at all, like sometimes happens in acute coronary syndromes. You know, I criticize people not doing pre-dilatation, but occasionally I also do in some acute coronary syndrome where I believe it's purely thrombus. Sometimes there is around a hard shell of calcium that doesn't expand.
Okay, there was one question about, let's say, the pathology of calcium. So obviously it could be superficial, it could be deep, it could be nodular, it could be concentric, it could be focal, it could be diffuse. Are there particular, let's say, characteristics where you should very early think, okay, I'm likely to, after imaging, of course, I'm likely to need shockwave? Or are there particular types where you might say shockwave is likely not to have a benefit, and think of something different?
Well, I think I'll revert a little bit the question. I think shockwave is likely to have some benefit anyway, probably also in very eccentric lesions, of calcified lesions. However, if we have to draw a line, which is also related to cost, obviously you will go more easily to lesion that you can't expand any other way than on lesions where you just have to use a bit more pressure in your balloons. So for eccentric lesion, for deep calcium, I think it's obvious that trying with the balloon first is probably a good way of doing it. The three criteria of the Fujino means classification for OCT, provided you are able to have an OCT before, because sometimes the calcification of the lesion is too severe and you can't cross or you can't flush the lesion, I think are an indicator, but they are not the truth 100%. You know, you can have a 360-degree, very short lesion that opens up easily with a balloon. You can have a 270 longish lesion that is extremely resistant to anything. So I think thickness is one point that OCT adds, and I would try to measure that carefully, because if you have thin calcium, response much better than thick ones.
Okay, thank you. So a couple of questions in the chat. Let's take those. So first question is, what could be the role of shockwave in calcific in-stent restenosis compared to other techniques? So treating in-stent restenosis becomes calcified. What's the role of shockwave there?
Maybe I'll answer with a question. Has anybody done a rotablation in one of such calcified restenosis of stents due to under expansion. And if you have done it, if you have heard the noise of a burr against metal, and you know how, again, unpredictable the result is, you enter balloons and 10 balloons burst one after the other against the broken struts, you will understand that you need a better technology. Forget it, just use IVL.
Okay. And then what about the role of, if you're trying to treat, let's say, long diffuse calcified disease, and you have a limited number of pulses in the shockwave? Is it a case of you need 2 shockwave balloons, or do you do like half and half, or what's your strategy in that setting?
Well, it is a young technology and is progressing with time. We have used yesterday for the first time in Europe the new peripheral balloon of shockwave, which is delivering half time the 300 pulses, and we hope that similar technologies will become available also for coronaries. For coronaries, the reason why they are not allowed to deliver more than 80 is well, the very cautious attitude of FDA that looking at the number of balloons that ruptures after the delivery of pulses, wanted to have really 100% not bursting. Still they burst because of course they may be damaged when you insert them into this calcified lesion, but it's not due to the energy inside. Probably you can already increase that to probably double, but they are working on that and hopefully will be available soon. For the time being, we are forced to use 2-3 balloons that sometimes are also required, because if you have a taper vessel, you need a balloon precisely of the size of the vessel. I won't say EEL to EEL, but at least that touches the wall nicely, otherwise it doesn't work.
Okay, so we have a few more minutes and we'll take these last few questions. The instructions when using shockwave are quite specific: 4 atmosphere, specific mixture of contrast saline. In your experience, for those of us who are starting using shockwave, are there certain things we can do or tips and tricks to improve the efficacy of shockwave, or to make, you know, when we take the cost and take the hit for the patient, make sure we get the most, let's say, bang for our buck?
Well, I mean, again, probably number one is choose the appropriately sized balloon. And when you start, you know, normally you are used to do pre-dilatation with a small balloon. That doesn't work with shockwave. So consider the final stent you are going to use. That's the size of the shockwave balloon you should apply. Then prepare well. Remember that, you know, this technology will always generate bubbles. So after the first couple of pulses, maybe withdrawing your 50 saline contrast to avoid that those bubbles somehow reduce the efficacy of the treatment might be worthwhile. Also, there are no real data about it. I think the pressure can be used a little bit in a flexible way. You can start, if you really, you know, going with a vessel that is 1 millimeter lumen with 1-2 atmospheres, as long as you see the balloon open, and then see it creating a space with the energy of the lithotripsy. I would go for the 4-6 at the end of the cycle. Don't move too much. I mean, in the study, all balloons were inflated twice and activated twice at the same size. Then you were moving half balloon and delivering again 2 times. And if you needed more than 1 balloon, you needed another one. If you want to replicate those results, that's the way you should do it. And I'm still doing it. It's a bit an expensive and lengthy process, but it works. And I hope Pierluigi can confirm that.
Yes, the preparation is fundamental.
Great, really useful tips. Thank you. I think I hope many people were writing those down, and very useful tips for us. So last question we'll take is regarding antiplatelet therapy after shockwave. Do you have any different considerations or as normal?
Well, I mean, whenever you expand better your vessel, you obviously are less troubled by the potential risks of leaving a residual stenosis that can be a cause for thrombosis. Having said that, in general, these are long calcified segments, complex lesions, and definitely you would like to have the patient properly treated with antiplatelets. Nowadays, I don't know what's the best way, because of course with stable lesion like these are in most cases, you tend not to pre-treat, and giving clopidogrel on the table, that's not the most efficient way to obtain optimal antiplatelet treatment. Going for intravenous cangrelor, that's again no data, evidence-free space. Going for novel antiplatelets that are not so novel, like ticagrelor and prasugrel, they cost nothing, so you can use liberally, except again is evidence-free in stable syndromes. So is a field where I really am not behaving like a scientist, but more following what is the bleeding risk of the patients and the complexity of the lesion, and adjusting those drugs and those treatments according to these points.
Okay, brilliant. So we're at time now. So I'd just like to say big thank you to all of those who joined in and participated, and thank you for your questions as well. They really add very much to the discussion. Pierre, big thank you for the presentation. Really nice summary, so really appreciate it. And finally, a big and warm thank you, Professor De Mario. You really enlightened all of us with the shockwave, and we take your messages very much on board and into our cath labs in the future. So a big thank you for joining us. We hope you'll be back. And so take-home messages are: it's clearly a safe device, very efficacious in treating a broad range of simple and complex coronary lesions. The technology is improving, but it's important we know not just to use shockwave, but how and when to use shockwave. So with those messages, I'll leave you. Wish you all a good weekend, and see you again next week. Thank you, everybody.